would like to welcome all of you here tonight for our Society of Skeletal Radiology's Resident Education Club webinar. My name is Bethany Casagranda from Allegheny Health in Pittsburgh, Pennsylvania, and I will be serving tonight as your moderator for the session. It is my great pleasure to introduce our speaker for the webinar this evening, Dr. Christian Geannette. He is coming at us live from Cornell, as they say, Weill Cornell Medical College in New York City. He's an attending radiologist at Hospital for Special Surgery and an associate professor of clinical radiology. He serves as the director of radiology education and musculoskeletal radiology fellowship director at HSS. He completed fellowship training in both musculoskeletal and neuroradiology. So the cool kids and maybe the not so cool kids. And now he's going to be an enigma. We have to watch how he does tonight. While he reads all diagnostic modalities, he has a particular interest in ultrasound procedures, diagnostic ultrasound, and peripheral nerve imaging, as well as sports imaging. In addition, Dr. Geannette serves as the in-game radiology consultant for the New York Mets. So we will, I'm a hockey fan, so you got lucky. All right, Dr. Geannette, the floor is yours.
Right, Dr. Casagranda, thank you very much for that lovely introduction. And welcome to this SSR webinar. I'm super excited to give this because I was given the topic of the elbow, and the elbow is my favorite joint. So for those of you out there, I hope you enjoy these next 9 cases as well. The way I've structured tonight's webinar, I am going to, I'm going to show you the cases as anonymous cases. I'm gonna give you 5 to 10 seconds, maybe 15 seconds to sort of think about the cases and come up with a diagnosis yourself. I might ask you a couple different questions and prompt you, and then I'm gonna go through the annotated images and the answers of the cases. If you have any questions or comments, feel free to add those to the chat box, and we'll try to address those at the end of the webinar. So without further ado, let's get started. No interesting financial disclosures. So case number 1, from left to right, we have a sagittal inversion recovery sequence. In the middle image, an axial inversion recovery sequence. Most importantly, notice that this axial inversion recovery sequence is at the level of the proximal forearm, and more specifically at the level of the radial tuberosity. And on the right, we have an axial inversion recovery sequence at the level of the distal humerus. This patient has pain in the antebrachial region. So let me give you 10 seconds to think about this. What do you think happened to this person? And why am I in particular showing you images at the level of the proximal forearm and also at the level of the distal humerus? And how does that pertain to the pathology that we're showing you? Good. So we already see some answers. Excellent job from some of the residents in the audience. So this is a distal biceps tear. Now let me take you through the images. On the left sagittal inversion recovery sequence, we see soft tissue edema that I've outlined with that orange dash circle. And we see, denoted by that white arrow, a torn retracted distal biceps tendon. Now, what do we see in the axial inversion recovery sequence? And why did I show you it at the level of the proximal forearm? Well, we see soft tissue edema and absence of tissue in the region of the radial tuberosity, meaning that this is a distal biceps tear. Now, sometimes you can see a stump of tendon, even in the setting of a complete tear of the distal biceps, but in this case, there is no distal stump of tendon. Let's now look at that right-sided image, that axial inversion recovery sequence at the level of the distal humerus. Again, we see edema, right, denoted by that orange dashed circle. We also see the torn and proximally retracted biceps tendon. The reason that this site is interesting and important is that we need to assess whether the lacertus fibrosus is intact. In this particular case, the fact that the distal biceps is proximally retracted, we can presume that the lacertus fibrosus is torn. Now, what is the lacertus fibrosus? We're going to look on this next image. So The left-hand image is that same axial inversion recovery sequence. The right-hand image is an axial proton density sequence at the same level. We see that torn biceps tendon denoted by the white arrow, and then we see the torn lacertus fibrosus denoted by the red arrow. So the lacertus fibrosus, also known as the distal bicipital aponeurosis, is what I like to think of it as a seatbelt. So when the distal biceps tears and it starts to proximally retract and recoil, the lacertus fibrosis in some cases can prevent the proximal retraction of that distal biceps tendon. However, if it is torn, you're going to see more of a proximal retraction of that distal biceps, as we see in this case. Now, it's very important to recognize these cases, obviously, but it's also important to assess them early. These have much better operative outcomes if they're operated on within the first 4 weeks. Otherwise, the surgery becomes more complicated for our surgical colleagues. Sometimes they'll have to use autograft for that reconstruction. Here's a sagittal proton density sequence redemonstrating that torn and retracted distal biceps, at least to the level of the elbow joint. On the right-sided image, the sagittal proton density sequence, we see again the absence of tissue at the radial tuberosity, confirming the distal biceps tear. Radiographs, frontal and lateral radiographs demonstrate fixation anchor in the radial tuberosity status post distal biceps repair. Now, if you're watching, please burn these images into your mind, okay? This fixation device is in the radial tuberosity, right? The radius. Okay, so again, burn this into your mind because we're going to now have a companion case. Case number 2. This patient comes to us years after a distal biceps repair, and the primary complaint is difficulty pronating and supinating the forearm. I'm going to let you think about this for 10 or 15 seconds. Pay particular close attention to where the fixation device is. Other thing you should note is, where's the surgical tract? Is it involving one bone? Is it involving 2 bones? So this is a case of distal biceps repair, what I deem as gone awry. Never seen another case of this. So what do we see here on these frontal and lateral radiographs? Well, we see that the fixation anchor in the proximal ulnar shaft status post distal biceps repair. It is not in the radial tuberosity, and we see, as we see by this dashed red line, a tract through both the radial tuberosity, but then extending to the ulna and site of fixation. So what does that look like then on our cross-sectional imaging? Where here are sequential sagittal proton density images, which demonstrate the distal repair to extend through the radial tuberosity to the ulna. Here's that tract. Here's that tract again. And here's that tract again. So this is definitely explaining why this patient is having difficulty both pronating and supinating the forearm. If you didn't believe me on the sagittal sequences, here are the axial sequences. That for orientation, the bone where the white arrow is the radius, the other bone more dorsally is the ulna. We see by these white arrows the tract in the radius. But then we also see on further imaging the tract extending into the ulna, which is obviously something that we do not want to see. Case number 3. I'm going to give you 15 seconds to think about this case. Just so you know, the sagittal inversion recovery sequence on the left, the middle image is at the same level. It's a sagittal proton density sequence, and the image on the right is an additional sagittal proton density sequence, but more off midline. I see some answers coming in, and so looking at those answers, I would probably ask you to be a little bit more specific with your diagnosis. Okay, so let's take a look at the answer. Yes, so for those of you that answered that this is a distal triceps tear, you are indeed correct. I think since going into those of you going into MSK radiology, this is a really nice case demonstrating the anatomy of the triceps. So what do we see here? Well, first of all, the triceps is made of three components, right? So what are those components? Those are the muscular, the long, and the lateral heads. Now, the lateral and the long heads are conjoined, and they make up the posterior half of the triceps footprint on the olecranon, here denoted by that red bracket, whereas the muscular attachment makes up the anterior half of the olecranon footprint. Now, what I like about this particular case is I could see where you could, call this a high-grade triceps tear, but then it'd be a little confused, right? So you told me that the muscular medial head involves the anterior 50% of the olecranon, right? So why are we seeing tendon? Well, some of that muscular attachment to the olecranon, that muscular attachment of the medial head, can have a tendinous component, as it does in this particular case. I want to go back to these images still. Stay on these images. You'll see in the rightwardmost image that torn and retracted conjoint lateral and long head of the triceps. So the teaching point here is that the medial head of the triceps has a muscular attachment that can have a little bit of a tendinous component, and it typically attaches to the anterior half of the olecranon footprint, whereas the conjoint long and lateral heads attach to that posterior half. You can have isolated tearing of one component or the other, as seen in this case, or in some unfortunate cases, you can have a complete tear of the triceps tendon. As if you didn't believe me from the sagittal images, here are axial inversion recovery and proton density sequences at the same level, demonstrating the edema on the inversion recovery sequence at the site of the absent, torn, and proximally retracted triceps tendon. I should say the lateral long head of the triceps tendon. Next case, case number 4. I'm going to give you 15 seconds to think about this one. The image on the left is status post-pinning of a supracondylar fracture. The image on the right is 2 months later after the hardware has been removed. This is, I think, a two-part question. So what do we see here? Well, obviously they've removed the hardware, and then children have really exorbitant periosteal new bone and callus formation. So you see that they healed. Now, did they heal appropriately? That's the question. Here again is the marked periosteal new bone formation. Well, as of right now, I don't know. I think it would be difficult to say too much in terms of wayward healing. This patient then came back several years later. Now what do we see? And I think some of you actually had the correct answer just based on that 2-month follow-up radiograph. I think that's a very hard call, if not impossible. But now what do you think? And allow me to draw your attention particularly to the contour of the distal humeral articular surface. Is that normal? You're all radiology residents, so you're smart. So just by the way that I answered asked the question, you probably know the right answer. So the answer is no. Look at this contour abnormality of the distal humeral articular surface. Right? And this marked undulation and depression of the central aspect of the distal humerus. Now, what do we call this? Well, this is an unfortunate complication of a supracondylar fracture. This is called a fishtail deformity. Essentially, this is the central aspect where the condyles meet is a watershed area. So in this small percentage of patients, you can have essentially a decreased blood flow to this area, which results in this terrible deformity. Now, again, it's a rare complication. It's favored to be due to avascular necrosis, and it's prone, this kid is now going to most likely have functional impairment, early arthritis, and pain. So an unfortunate complication that we see every once in a while. You see that contour abnormality both on the radiographs here and then also on our middle image, the coronal proton density sequence, in our right-sided image, which looks a little funky. This is a physeal sensitive gradient type sequence that we use for all of our pediatric patients. Next case. Don't jump to the keyboard too quick because the question is not whether this patient dislocated or not. They did. So this is now status post-reduction. I want to ask you a series of questions I want you to think about. First is, how old is this patient? The second is, how did you come to that conclusion? And I'll get to the third, but I'm going to give you a couple seconds to think about those first two questions. So now that you've thought about how old the patient is and how you came to that conclusion, I'll obviously give you a leading question, but what is the crito mnemonic? So let's take a look. So this patient has been reduced. Have they been reduced appropriately? Well, it wouldn't be a case, right? In the webinar, if they were reduced appropriately. So they were not reduced appropriately. This person is status post-reduction and there's a problem. Okay, so let's go through crito. Crito is a mnemonic and it's the order of elbow ossification centers and when they ossify. So the C in crito, and that is in order. The C in crito involves the capitellum. The R in crito involves the radial head. The I involves the internal epicondyle, i.e. the medial epicondyle. Do we see that? Probably should be here. I don't see it. The T involves the trochlear ossification center. The O involves the olecranon ossification center. And the E involves the external or lateral epicondylar ossification center. So right here. The way I remember these are basically 1, 3, 5, 7, 9, 11. All right. So the C is 1 year, develops about when the patient is about 1 year old. The R when the patient is 3 years old. The I when the patient is 5 years old. The T when they're 7. The O when they're 9, and the E when they're 11. So we can presume that this kid is probably 10 or 11 years old. It looks like they're starting to develop that external ossification center. But the problem here is we don't see the medial epicondylar apophysis, and we think it's displaced into the joint. So they're going to have to, unfortunately, go in on this kid, fish it out, and then put it back where it's supposed to be. And you see that they have done so in this post-operative radiograph, where they've put a screw through the medial epicondylar apophysis. Case number 6. I'll give you a little history. Let's say this patient is 30 years old. I'm not going to give you any more history other than that for the time being. I'm going to give it another 5 seconds and then we'll continue. Good. So a lot of you are filling in some really smart thoughts. So what do we see here? Well, is this normal? Absolutely not, right? Particularly on the lateral. I think the frontal, look at that radial head. It looks a little strange. Hard to say exactly what, but on that lateral, at least if I were reading these radiographs, that radiocapitellar articulation looks quite narrow. It looks like bone on bone to me. What about that radial head? Does it look normal? And if it looks abnormal, does it look small? Does it look big? So to me, it looks real big. I use the word ballooning. And so, as many of you said, this is a case of hemophilia. So let's look at some of the advanced cross-sectional imaging. On the left-hand image, we see a coronal inversion recovery sequence. We see bone marrow edema surrounding a capitellar erosion. On the right-hand side, we see a coronal proton density sequence, and we see that severe radiocapitellar joint space narrowing, which we knew about, and then we also see that capitellar erosion. The sagittal proton density sequence on the left, we see the radiocapitellar synovitis, and we also see, or get a hint at least, of the synovium lined with hemosiderin. On the right, we see a coronal MPGR, so a gradient sequence in the olecranon fossa synovitis. And you can see that this synovium looks pretty thick and hypointense, stained with hemosiderin, right? So what is hemophilia, right? So you have these spontaneous hemarthroses that often results from very minor trauma. You get some proliferative, chronically inflamed synovium, results in this repeated bleeding, and then this hemophilic arthropathy, right? You have iron that is deposited into the synovium. You have neoangiogenesis, very friable vessels, which keep on bleeding, and that inflamed amalgam then leads to chondral damage, typically seen in large joints, of which the elbow is one. So what are the other types of joints that you might see? You might see the knee, the ankle, the hip, the shoulder. Now the gradient, something that I'm sure you're all well aware of, that'll demonstrate some blooming artifact as we see here. Okay, what are the other things that bloom? In addition to blood products like hemosiderin, well, hemorrhage does, like we said, calcification, metal, gas. Good. Someone put PVNS. Yeah, that's a great one, right? That's an excellent one. All right, case number 7. This person has medial sided elbow pain. I have the frontal radiograph on the left and the blown up image on the right. What are your thoughts? So we see a focus of mineralization overlying the medial epicondyle. I think it's safe to say that this is probably a case of medial calcific tendinitis. Okay, slightly amorphous. I find that when we try to aspirate these with barbitage under ultrasound, the more amorphous and fluffy they are, the more likely the calcium is to come out. So we do a little anatomy and then we'll get back to the case. On the left is a cadaveric image. On the right is an ultrasound image provided by one of my colleagues, Ted Miller. We can ultrasound these calcific tendinosis cases and potentially intervene on them. So how do we do that? Well, we supinate the elbow, we extend the elbow, and we place the probe in this manner. What does that look like? Well, the right-hand image is our ultrasound image, and then our left-sided image is our MR correlate. It's a coronal proton density, but I've flipped it on its edge so that we're comparing apples to apples. You'll notice that the black arrows denote the ulnar collateral ligament, while the white arrows demonstrate the common flexor origin. Getting back to our case, this is a longitudinal orientation of that flexor pronator mass. That white arrow is demonstrating that what on this image looks like a small echogenic focus of calcium. Really, the point of this slide is to demonstrate this markedly abnormal appearance of the common flexor pronator origin. Now, normally on ultrasound, you should have a nice fibrillated appearance of flexor and pronator tendons. Does this look fibrillated or rope-like? Doesn't to me. So this whole area is ill-defined, hypoechoic. This is severe tendinosis. Now let's look a little bit more at that echogenic focus, right? So this echogenic focus, the left-hand ultrasound image is a longitudinal image, whereas the right-hand image is a transverse image. This echogenic focus that I'm talking about, depicted by these white arrows, is the calcium that we saw on the radiographs, and this is a focus of calcium in a case of calcific tendinosis. Now, does this look like it hurts? Probably, right? So we put some color Doppler on here. Look at all this hyperemia. So if you're going to put a needle into this focus of calcium, you need to let the patient know that this is going to hurt. So I think that managing expectations, particularly if you're doing a lot of image-guided procedures, especially in MSK, you really want to set expectations and let them know what to expect. That'll make your life easier going forward. Case number 8, so we have 2 more getting there. Coronal inversion recovery sequence on the left, a coronal gradient or MPGR in the middle, and a coronal proton density sequence on the right. This is a baseball pitcher who felt acute pain. I'm not even call it a pitcher. I'm going to say this is a baseball player that felt acute pain. What is your diagnosis? I think this is best seen on the coronal inversion recovery sequence. And then once you see the abnormality on that sequence, you can then look further at the structure in question on the coronal MPGR and the coronal proton density sequences. So this is a ulnar collateral ligament tear in a baseball player, all right? The coronal inversion recovery sequence demonstrates the edema, all right, as well as the absence of tissue, i.e. the tear. This is a proximal tear of the UCL anterior bundle. We won't get too much into the anterior versus posterior bundles or the anterior and posterior bands of the anterior bundle tonight. But this is a high-grade tear. If this is a pitcher, he is going to get ulnar collateral ligament reconstruction, i.e. Tommy John surgery, if it's a high-level player. If it's a fielder, it depends if it's the non-dominant arm or if it is the dominant throwing arm. If it's the non-dominant throwing arm, they might PRP this and give him some rest and allow him to play. The other thing that's interesting here, without getting too much into the weeds, is this is a proximal tear. Proximal tears tend to heal better in the non-operatively than the distal tears. So probably more inclined in a non-pitcher to try non-operative management, see if this heals. What does this patient look like on the axials? Now, coronal is going to be your workhorse for the anterior bundle of the ulnar collateral ligament. But you also want to look at your axials. I think that's generalizable in our field of radiology. If you have other sequences, you should use them. If you have other planes, you should use them. Okay, so here we see on the left-hand image that inversion recovery sequence, a lot of edema about the nerve. You also see hyperintensity of the ulnar nerve. It is not uncommon for patients in the acute setting of an ulnar collateral ligament tear to also have an ulnar neuritis. On the right side of the image, you'll see that that blue arrow depicting the posterior bundle of the ulnar collateral ligament. Very briefly, let's delve into the anatomy. The ulnar collateral ligament, when you think of it, you should think about the anterior bundle and the posterior bundle. Those are the two dominant bundles. The anterior bundle happens to be made up of both anterior and posterior bands, which reciprocally are taut or not taut, depending on the degree of flexion when the patient is in valgus. The anterior band of the anterior bundle tends to be the primary restraint between 0 and 90 degrees and is therefore injured at 0 to 90 degrees. In this bottom right-hand image, I just gave you a nice cartoon that demonstrates what I mean when I say 0 to 90. So 0 degrees of flexion equals terminal extension, all right? Now, again, real briefly, I want to talk to you about the anatomy, the normal anatomy of the ulnar collateral ligament. It should be taut, okay? So there's a couple things that are very important. It should be taut, and you shouldn't see periligamentous soft tissue edema on the IR, okay? If it's wavy or redundant, some alarm bells should go off in your head that maybe there's a tear, okay? That's the first thing. If there's periligamentous edema in the acute setting, alarm bells should be going off in your head that there's possibly an acute tear. Now, there is often signal in those proximal fibers of the UCL off the medial epicondyle, and that is normal, okay? Those are fibrofatty slips that insert into the fibers and interdigitate between them. Don't start overcalling UCL or partial UCL tears because you see that, okay? Here's the ulnar collateral ligament and the ulnar nerve in a normal patient. The orange arrows are depicting the posterior bundle of the UCL, which makes up the cubital tunnel. And you can see that the ulnar nerve sits nicely in that cubital tunnel. The ulnar nerve is depicted by the blue arrow in this case. Last case, we're nearing 7:30. Just think of how you would describe this in a report. I'm not going to ask you to write that in the chat box, but think how you describe this elbow in one of your reports and think of what your diagnosis would be. I'll give you another 10 seconds. So what I'm seeing here, I'm seeing dislocation, I'm seeing destruction, I'm seeing deformity and weird. The bones look very weird, right? I'm giving you a lot of D's, but that's not what this case is, okay? And when I said all those D's, you were thinking, okay, there's dislocation, there's deformity, there's destruction. I didn't say density, but basically I give you all the other D's for neuropathic arthropathy. This is end-stage rheumatoid arthritis, okay? And if we look at this, right, if you really look closely, you see that round, dense nodularity in the soft tissue. So always look in the soft tissues, you know, train your eye to always look at the bones clearly, but look in the soft tissues. You're going to find a lot when you do. Okay, so let's look at cross-sectional imaging to give ourselves sort of a further look into what's going on here. So you open this up and you think, oh boy, this is going to be a hard dictation. And it is, right? You have a systematic approach. You're going to get through these cases and you'll come up with a nice diagnosis. So these are sequential coronal images, proton density. And what do we see? Let's take one thing at a time. So the blue asterisks are synovitis. Now, if I was asking you about this synovitis, does it look fluid, like simple fluid, or does it look complex? It's pretty complex to me. If I talk to you further about it, would you give me more than just this is a complex synovitis? Would you suggest that there are rice bodies in there? Because I think that's a very appropriate suggestion. So now we have a complex synovitis question. We have rice bodies extending throughout the destroyed elbow joints. These yellow asterisks are actually intraosseous erosions. Okay, so that fits with rheumatoid arthritis. Now look, let me draw your attention to the ulnar nerve. We're going to go from left to right is proximal to distal. The red hours are depicting that nerve proximally in this left-hand image going to that area of synovitis. The middle image, you see the ulnar nerve actually going through the synovitis. And in the right-sided image, you're seeing that ulnar nerve course or exit out of that synovitis. So do you think this person has an ulnar neuritis? And do you think that is a raging ulnar neuritis? Probably, right? What do those findings look like on the axial inversion recovery and proton density sequences? Here we are at the level of the distal humerus. You see there is erosive change in the distal humerus. You see that the nerve on the axis looks like it's on fire, right? So this poor person has not only a destroyed elbow, but also a raging ulnar synovitis or ulnar neuritis. You see that ulnar nerve coursing straight through that synovitis. You can only imagine how irritated that nerve is. And then you see it coursing out of that ulnar synovitis. So I mentioned rice bodies. What are rice bodies and why are they called that? Well, in histopathology, they actually resemble polished grains of rice. And remember, they can be seen in synovial fluid, but they can also be seen in bursae or tendon sheaths, which I think is an important thing to know. Indeterminate whether we know the exact etiology of rice bodies. Some people say it may be shedding of infarcted synovium. So what did this patient get? This person got an elbow arthroplasty. And with that, I'll open up the floor to questions. That is the end of the cases. I think we did about 34 minutes, so I hope you enjoyed them. For those of you chatting in the chat box, pretty impressive. It looked like you really know your stuff. So like I said, happy to open it up to the floor now.
Dr. Geannette, thank you. I thought the cases were fantastic. I agree with you. I think that the engagement of the team was fantastic, even on the East Coast, right? And I know you've had a long day. People are still chiming in, which is great. I love the cases and the talking points. So thank you so much. It's incredibly educational. And elbow is tricky because some of the cases that you show are not things that we see every day. We read so much elbow, but not elbow that looks like that. And also some people get varying degrees of pediatric. So it was really nice that you had pediatric cases to complement the adult cases, which some of us are more used to. And I think that some of your cases had one answer, but others, when you get into the realm of inflammatory, right, you have differentials that are really important for all of us to kind of brush the dust off of. So it was excellent.
Thanks. Yeah, thanks for the feedback, and I agree. And to those residents who are still listening, you've made a great decision if you're going into MSK radiology. It is an awesome field, whether you like diagnostics or procedures. The topic of the elbow, I think when I was in your shoes as a second or third, even fourth year resident, I saw almost no elbow cross-sectional imaging. So if you felt like, oh man, I'm a little lost, don't worry about it at all. It's something that you'll learn going forward, and particularly if you end up in this subspecialty, it's a really fun joint too. So.
Yep. I completely agree. I know that Patrick said you can post any questions to the Q&A section of the Zoom. So please feel free to do that. But if we don't see anything pop up, I definitely wanted to thank Dr. Geannette for his time. I think you did a remarkable job. I want to thank the audience. We have a lot of people here tonight, which is fantastic, absolutely fantastic. And it's a wonderful series for sure. Our next lecture is December 13th. 2023 at 7 o'clock, same bat time, same bat channel. And instead of elbow, they're going to be doing interesting shoulder cases. That presenter is Dr. Maxine Kress. So that's going to be fantastic. So unless there's anything else, I think Dr. Geannette, your long workday has finally ended.
Great. Thank you. Thanks everyone for coming. And yeah, we look forward to seeing you as colleagues down the road.
Fantastic. Good to see you.